Hey y'all, it's AJ. We're going to talk about ovarian cancer. This is for nursing 2912, fall 2021. I figured I would start with the patient's demographics over the case study that I was going to present. The patient's name is Karen. She's 48 years old, African American female, obviously. She was Christian, very Christian, like to the point she would have church playing on TV. From Macon, Georgia. She had 6 children who are all boys. She's not married and lives at home in Macon with her mom and her oldest son, and he has 3 kids, her 3 grandchildren that live in the home with her. She presented to the emergency room with complaints of severe abdominal pain and vaginal bleeding. Her vital signs were stable. She reports that she went to the OBGYN recently for a checkup, but she didn't really include what the checkup entailed. She just said that she hadn't received a call from her doctor concerning the results. In the ER, she had a line placed, an IV, and was sent for a CT scan. Her ECG came back normal, and the urinalysis was obtained. That came back not remarkable. Upon reading the results from the CT scan, the doctors decided to admit her because the mass on her ovaries was later identified as adenocarcinoma, a type of cancer. We know that cancer is a disease process that begins when the cells are transformed by mutations and they basically just keep growing, which causes the mass. Ovarian cancer is often linked to genetics. That's in chart 15-1 in our MedSurg book. She did say that she didn't know of any history of cancer in her family as far as like mother and grandmother. No aunts or uncles, she said, had cancer that she was aware of. This was just a hey, look kind of thing. Since she came in with her first sign being vaginal bleeding, she was obviously postmenopausal. I just wanted to note that vaginal bleeding is a lot of the times the first symptom we see that causes us to do CT scans or x-rays or anything like that often lead to finding cancer, female cancers. Because of the how big the mass was in her ovaries, GYNONC, which is Gynecology Oncology, it's a team we have up on 9 Main at Navicent in Macon. They decided to do chemotherapy. They thought it would be the best option for her. They went in and educated her, and she decided to go through with it. She was all right with it at first. She got what we call carbo and Taxol. Those are both short names. With pre and post hydration. So we know chemo destroys all cells, both good and bad. She was at risk for neutropenia definitely after receiving her chemotherapy treatment. It can be given orally, but typically we do IV at Navicent on 9 is what I've seen most of the time. She was a self-care patient and cleared by speech therapy and occupational therapy, so she did all of her bathing and self-care herself. And like I said before, her CT scan is what showed the mass and caused her to be admitted. The 2 drugs in yellow, carboplatin and paclitaxel, are the ones that we use a lot of times on 9 Main. This was just from an article basically saying, the whole article said that a lot of people that were receiving carbo and Taxol, amongst other chemotherapy drugs, there were only 2 deaths found possibly related to the treatment, and they weren't even sure if the chemo is what caused the deaths. For Karen, the mass throughout her stay eventually got bigger, so that ended up blocking her ureters, so her urine output decreased dramatically. The doctors then placed nephro tubes. If you don't know what they are, they're all nephrostomy or nephro tubes. They go in right above the hip area where your kidneys are. You can do them on one side or bilaterally. Hers were bilaterally. And basically, your pee comes out of the tube into a bag that holds around 600 cc's. Her urine was clear yellow. So she didn't really urinate like a normal person after that. There was very little urine output still once we did the nephro tubes as far as like peeing like a normal person. We did get social workers involved because the nephro tubes kind of worried her. She wasn't really sure about them. And I also would like to say that the number of cancer survivors is increasing dramatically just because of technology and development. We're able to treat it efficiently now. That's not to say that all cancer is treatable or curable or anything like that. It's just kind of amazing how many cancer survivors there really are out there. Karen had no idea what to think of the nephro tubes, so we used the time after the placement to educate her on how to use them and empty them and care for them after discharge. Her main concern after discharge was the fact that she was keeping the nephro tubes, and she had 3 grandchildren at home, and she didn't want them to kind of damage them or pull them out or anything. They are sutured in. So I told her, when you lay in bed, just lay them beside you in the bed with you. There's a little valve that you open and close to let the urine out. So she was okay with that. She was discharged home after her first round of chemo, and she tolerated it well. Her port was D-access, so of course we don't leave the needle in. You just take the needle out, remove the dressing, and place a band-aid. She could shower like normal. I will say that it was very shocking to her for the cancer diagnosis, and I've spoke to her recently. She'll be returning to the facility in a couple weeks for her second round, and I believe her care plan is going to be around 5 rounds of chemo, and then they're going to see where they go as far as like a hysterectomy to maybe remove all the female organs and get that mass as well. These are the references I used. The MedSearch book, of course, and the other 3 listed are just articles I found on Galileo, and I actually learned a lot from them. I hope this helped you out a lot, and I hope you learned a lot from it, especially about the chemo drugs and how it all kind of works. I hope you all are doing well, and we're almost done.